Here, sir.
Yeah.
We can
I'm
start.
ready, sir.
Yeah,
Whenever
please.
you're ready.
Yeah, we are
Okay.
ready. 7 o'clock.
Okay, sir. Okay, sir. Okay, going live in 5, 4, 3, 2, 1. We're now live.
Yeah. Hello, friends. Today we would be discussing the second module, which is something very, very important: bugs and drugs. Though we use antibiotics extensively, we often do not have adequate insight into it. And that is why we have arranged this module. So we have tried to break this down into small parts so that we could make it a little more interactive. And Dr. Aisha would be able to answer your questions. So this is today's roadmap: introduction to the module and world of microbes from an orthopedic surgeon's point of view, basis of antibiotics by Dr. Aisha. Then we will have a small debate between Dr. Aditya and myself. Then antibiotics for gram-positive bacteria by Dr. Aisha. Then she will also discuss gram-negative resistance and antibiotics for them. Then Dr. Aditya will come and explain how to avoid negative culture, because this is something very challenging, getting an appropriate culture or getting a positive culture. But if the culture is negative, then it becomes still more challenging, and Dr. Aisha will explain how to choose antibiotics in culture negative or even polymicrobial infections. Then, of course, we'll come to anti-TB drugs, which we will cover in short. And in addition, we will also discuss antifungal and soft tissue infections. At the end, Dr. Aditya will discuss what we learned today. So it's my great pleasure to introduce Dr. Aisha Sunawala, who is an infectious disease specialist. She's a consultant in Division of Infectious Disease Specialist. She heads the Fellowship of Infectious Diseases. She's a secretary of Antimicrobial Stewardship Committee at Hinduja Hospital. She is a co-author of a casebook of HIV medicine, also a co-author of ICMR National Treatment Guidelines for antimicrobial use. She is also a member of Scientific Steering Committee for Indian COVID, and she has done extensive work during the last 2 years. And of course, a committee member for National White Paper documents for resuming safe air travel in Airport Joint Advisory Committee. So we welcome Dr. Aisha. Can you stop your video, start your video, Aisha? I will stop sharing so that you can, yeah. That is Dr. Aisha Sunawala. Welcome to the group, Aisha, and welcome to this module.
Thank you, sir, for that introduction, and thank you so much for having me here today. We have a lot to catch up on in limited time, so I think we'll start with the presentation.
Okay.
So you'll need to stop sharing so I can share my screen.
No, I'm going to have the introduction first.
Yes, so you go ahead.
Can you see my screen now?
Yes.
Okay. So we'll start with the questions that I had posed. Whether this pattern represents MSSA or MRSA or doesn't fit into classification. 1/3 have said this fits into MSSA. 40% have said that this is MRSA, and about 1/4 have said that this doesn't fit into classification. Please read this Staphylococcus epidermidis. Dr. Aisha will explain in detail the difference between Staphylococcus aureus and Staphylococcus epidermidis. So this actually doesn't fit into this classification. Now, whether this pattern fits into MRSA or MSSA, 73% have said that this fits into MRSA, while 20% have said that this doesn't fit into the classification. Now, again, here you need to check. One is cefoxitin screen, which is positive, and it is resistant to oxacillin. So it is MRSA. Now we had asked, please enter antibiotic of your choice for methicillin sensitive Staphylococcus aureus. And again, this Dr. Aisha will explain in detail. Now these are next few slides are just bits and pieces I have picked up in my journey of 40 years of practice. And I have tried to put it in our language, that is orthopedic surgeon's language, which again will be elaborated by Dr. Aisha. These are the various answers for antibiotic of your choice for methicillin sensitive as well as the resistant bugs. So coming to microbes world, there are several, people say that there are about 7 different types of microbes, but we are more concerned about bacteria, protozoa, fungi, and now viruses. Most of them are beneficial in producing oxygen. They decompose organic material and they provide nutrients for the plants. They also maintain human health, especially most of our gut organisms. However, some can be pathogenic and cause diseases in plants and humans. Coming to bacteria, there are cocci or round shaped, there are bacilli which are rod shaped, they can be vibrio, they can be spiral, etc. Based on the oxygen requirement, they can be aerobic, that means living in presence of oxygen, or they can be anaerobic, living without oxygen, or they can be facultative anaerobes, that means they can live in both the environment. According to the staining characteristics, they can be gram negative, as you see here, or they can be gram positive, which stain violet with gram stain. Gram positive produce exotoxin and they have a thick cell wall, while gram negative produce exotoxin as well as endotoxin and have an outer membrane which gives some kind of antibiotic resistance. Now, WHO has declared some bacilli as most troublesome, and most of them are gram negative, which include Acinetobacter, Pseudomonas, Enterobacteriaceae, Klebsiella, E. coli, and Proteus. So in short, they are more resistant than gram-positive bacteria and cause significant morbidity and mortality worldwide. As regards acid-fast bacillus is concerned, we all know MTB. However, non-tubercle mycobacteria are also well known and cause orthopedic infections often. Fungi are of different types, which often generally are useful. However, they can also cause infection. Now, these bacteria are always present on our skin, or what is called a skin flora, which is different in different areas of the body, depending on whether it's a moist skin or a dry skin. And the commonest bacteria are Staph aureus, Coagulus positive, Coagulus negative, or cons, Propionobacter, and Corynebacter, also Streptococci. So during inflammation, the bacteria can invade into the body. Also, these bacteria can reach bones by hematogenous route And the various different bacteria of genitourinary are here. Gastrointestinal have a different flora. Oral cavity has a different flora. All of them can reach the bones by hematogenous routes. We have already discussed that open fractures can introduce soil organisms as well as water organisms in our body. Coming to orthopedic infections, the commonest are surgical site infections, chronic wounds, and hematogenous infections. So let us discuss a bit about surgical infections. So within no time, surgical field is flooded with bacteria which are in planktonic form. They keep moving as single cell, and therefore when you give antibiotics, they are killed, or even body's defense mechanism can act against them. However, if the situation is favorable for bacteria, some succeed to attach to the implant or surgical site. They get attached to each other and recruit more planktonic bacteria. Body tries to form a membrane which prevents this invasion, and a classic terminology is race for surface. Bacteria try to form a covering, body also tries to form a covering. When the tissues are traumatized and avascular and host defenses are poor, bacteria secrete this extracellular matrix and get embedded in that and start biofilm formation. This colony starts getting established, and then it forms pathways for nutrients, and they generally are into three layers: the superficial, the second layer, and deep. The superficial layer has highest oxygen concentration. The second layer down-regulate the metabolic activity, and third, the most troublesome ones are about 1% of the entire colony. They are deep, they are dormant, and least metabolically active. They are unresponsive to antibiotics, not necessarily resistant to antibiotics. Please read this fantastic article titled "The Techno-Theoretical Approach to Management of Osteomyelitis." One thing that people have found is there is something called quorum sensing, or act of communication between microbes, and they carry out colony-wide functions. Even though they are unicellular, they work as polymicrobial or Aisha, what is it called? Colony-wide functions of sporulation, virulence, biofilm formation, and dispersion. So these films keep bursting in between and can cause acute symptoms and local and distant infections. The biofilm can also go underneath the implants, and once biofilm forms, the white cells really cannot act on these bacteria. There may not be any pain. CBC, ASR, CRP may become normal, and culture may not grow. It is called frustrated leukocytes start going underneath the implants, and with bacterial toxins can cause osteolysis and implant failure, and that also would cause bursting of biofilms with acute symptoms. In case of nails, the entire medullary cavity can be covered with biofilm. So they are essentially not static fortresses. They are incubators of fast-growing virulent bacteria that disperse to populate new surfaces and slow-growing antibiotic-resistant or tolerant persistent cells. So if we have to salvage fixation or suppress infection till fracture healing, we need to attack early, and that early is as early as possible. Not with antibiotics or not with empirical antibiotics that can kill only planktonic bacteria, but with surgical knife, which will remove the adherent biofilms and get samples. And then the planktonic bacteria would be killed. The site becomes sterile, and we will be able to salvage the fixation. So in short, friends, we are dealing with the safe abort for bacteria, which is very challenging for surgeons and is a disaster for patients. There are several other sites where bacteria can reside, and that is why, remember, debridement is just not removal of pus and implant. It's a much more serious business. With this small introduction, I'll request Dr. Aisha to explain to us which microbes form biofilm, which antibiotics can penetrate biofilm, what are the different types of antibiotics, how to choose antibiotics, and so on and so forth. Over to you, Dr. Aisha.
Thank you, sir. That was really such an ingenious introduction. And I'm just going to start with a few introductory slides. So I can share my screen once you have put yours.
Yes, that's why I'm trying. I'm not able to unshare my screen.
So see at the bottom, there'll be a toggle saying stop share.
Yes, there it is. Yeah.
Oh.
Yeah, please go ahead.
Okay. So I think we've had a really interesting introduction with all those animations and all. And I'm just going to plunge right into a very simplified classification. To begin with, why am I here today? And why are we discussing this? Because really, we've reached this stage. Either most of our antibiotics are being pummeled by our bugs, or our bugs have already emerged victorious over them. So we really have to very judiciously appreciate, understand, and use what we have left. Dr. Agashe just went over this classification, and I'm going to just name some of the most important bugs that we see in orthopedics. The ones that I've highlighted are the ones that you most commonly see, the gram-negative pathogens that you most commonly see: E. coli, Klebsiella, Enterobacter, Pseudomonas, Acinetobacter. Some of the others that one will encounter in time is Proteus, Morganella, Salmonella, Burkholderia, sometimes Aeromonas, Bacteroides, which is an anaerobic gram-negative. What are the most common gram-positive bugs that we encounter? Staphylococcus aureus is by far the commonest, followed by coagulus negative staph, which Dr. Agashe showed us, the cons, streptococci, enterococci, the anaerobic gram-positives like Clostridia, and Propionibacterium, now called Cutibacterium acnes. So if we have to classify our drugs, let's start with our penicillin derivatives. We're going back a little bit into third MBBS time. And I'm going to try to simplify it as much as possible. So if you remember our synthetic, semi-synthetic penicillin derivatives, penicillin, ampicillin, amoxicillin. We also now have amoxicillin clavulanate, which is our augmentin. We have other combinations like ampicillin sulbactam, piperacillin tazobactam, like your Tazact or Piptazo. Then we have our cephalosporins. We have various generations of cephalosporins. And you might wonder why I put them in this order: first generation, then fifth generation, then second, third, and fourth. So I'll come to that. For the first generation, if we can just simply remember our drugs like cephalexin or cefazolin. Again, I put some of the most well-known brand names, just representative. I'm not endorsing any of these brands. This is the fifth generation cephalosporin that I want to introduce to you at this point, and it's called ceftaroline or Zinforo. It has just entered the Indian market last year, and I'll tell you a little bit about why I put it right after the first generation. We have the second generation, which is the most widely used: Ceftum, Supacef, Cefuroxime. Third generation, again, very widely used, ceftriaxone, cefixime, your taxim, Zifi, ceftazidime. And the fourth generation, which is cefepime. And finally, you have the carbapenems, which we're all gaining awareness of, ertapenem, meropenem, imipenem, doripenem. I'm sure you've had opportunity to use these as well. So these drugs that I've mentioned on the left here are, let's not say all this, but starting here, these are predominantly drugs that act against gram-positive organisms. As we go down, from the penicillins down to augmentin, ampicillin, sulbactam, piperacillin, tazobactam, as well as we go down these generations, the drugs start becoming less effective for gram-positive and more effective for gram-negative organisms and broad spectrum as well. Except for the fifth generation cephalosporin or ceftaroline, which the USP of this is that it has excellent activity against gram-positive drugs, gram-positive organisms like methicillin-resistant Staph aureus and as well as other gram-positives. So that's why I put it higher up here. It has no gram-negative cover, very poor gram-negative cover, but excellent for gram-positive organisms. And as we go down this line, we have better and better gram-negative and broad spectrum cover. The same applies over here. As we move towards the carbapenems, we have better gram-negative and broad spectrum cover. So our carbapenems also cover gram-positives, but they don't cover things like methicillin-resistant Staph aureus, but they cover other gram-positives. So now let's look beyond the penicillins. We said the solely gram-positive drugs that predominantly cover gram-positive organisms are your penicillins, your first, second, fifth generation cephalosporin, vancomycin, teicoplanin, daptomycin, linezolid, clindamycin, azithromycin, rifampicin. The anti-tubercular drug is also excellent gram-positive activity. What about gram-negative drugs? Your third and fourth generation cephalosporins, aminoglycosides like gentamicin and amikacin, streptomycin, and aztreonam, which is a monobactam. These are predominantly gram-negative drugs. When we talk about broad spectrum drugs, and we're talking about beta-lactam, beta-lactamase inhibitors like amoxicillin, when we say BLIs, these are beta-lactam, beta-lactamase inhibitors. You have a beta-lactam like amoxicillin conjugated with a beta-lactamase inhibitor like clavulanate. Cefoperazone, sulbactam. This is the beta-lactamase inhibitor. Piperacillin, tazobactam. These all have broad spectrum activity. The fluoroquinolones have more or less broad spectrum activity. So do the tetracyclines like doxy, mino, and tigecycline, cotrimoxazole or Septran, as well as the carbapenems and other drugs like fosfomycin. Okay, so I'm going to stop here and I'm going to hand over to Dr. Aditya and Dr. Agashe, and then come in a little later again.
Thank you, Dr. Aisha, for a very nice introduction to antibiotics. Now we would discuss a bit about prophylactic antibiotics. Related to prophylactic antibiotics, we had asked a few questions. Which injectable antibiotic you give as prophylaxis in clean surgeries? 60% use third generation cephalosporins, 13% use second generation, and 1/4 use first generation cephalosporins. The duration of injectable antibiotics, almost 3/4 use only for 1 day, 3 doses for 1 day, and about 1/5 use it for 5 days. Now, almost 2/3 follow with oral antibiotic. Only 1/3 say that they would not give beyond 24 hours. How long do you give oral antibiotics? 1/3 say I don't give. 40% give for 3 to 5 days. About 20% use it for 7 days, and about 10-12% use it till suture removal. Most of the participants are aware that the international guidelines are to use injectable prophylactic antibiotics for only 24 hours and no oral antibiotic to follow it up. Well, there are people who do not follow this, justifiably so, because they feel that, or rather majority feel that they are not happy with OT setup, and a few feel that our patients are different. Now, those who are not very happy with their setup, I request you to join a series of 3 webinars by Maharashtra Orthopaedic Association starting on 6th March. This is a project initiated by our president, Dr. Gadegone, and the title is Operation Theatre, My Temple. And the basic idea is to improve OT conditions. Okay, now let's start with the debate. I represent a common orthopedic surgeon, common Indian orthopedic surgeon, and I feel that safety of my patients is important, and I would like to give antibiotics for a longer time, while Dr. Menon feels that more is less here. So I would say that I'll start with 2 or 3 antibiotics 1 day prior to the my surgery and continue it till suture removal, while Dr. Menon feels that nothing more than 24 hours is needed. And of course, Dr. Aisha Sonawala will decide who is right and who is wrong. Now, Dr. Aditya and Aisha, you agree that biofilms must be prevented. And therefore, antibiotics have to be given before inflating tourniquet and repeat if need be. There is no debate, correct?
Correct.
But I want to play safe. And I feel that rather than giving antibiotic just prior to surgery, I would start 1 day prior. I give at least 2 antibiotics, which will cover both gram-positive or gram-negative, or maybe broad spectrum antibiotics, which Dr. Aisha has explained. And I'll continue with 1 to 2 weeks of oral antibiotics. I justify my statements based on 3 things: common sense, Indian literature, and majority wins. Common sense. Aditya, you have insurance?
Yes, of course I do.
Aisha also. Why? Because you want to play safe. And what is your premium? Certainly not 400 rupees or 200 rupees, correct?
Much more.
You like to buy insurance which is worth thousands. Am I right? So, when so many bacteria are going to invade my surgical field, I would like all these bugs to be killed before they enter my patient's body, or at least within first few minutes of my surgery. So I'll start my antibiotics 24 hours before my surgery, kill all these bugs, and whatever remain when I operate, I will continue with these antibiotics and just kill all the germs. I'll continue and continue and continue till I have nothing, and still I'll flood the field with antibiotics so that there are no chances of infection. This is the psychology of most of the orthopedic surgeons, or many of the orthopedic surgeons. Things are changing, but at least 50%
I think there was an internet issue there. Sorry, everyone. I think there was an internet issue and some a technical issue with Sir's laptop. So what we'll do is we'll get back to the debate once Sir is back online. I would request Dr. Aisha to take her next talk on gram-positive bacteria. Dr. Aisha, could you take over?
Yeah,
We'll continue, get back to the debate
Sure.
once Sir is back online.
Sure.
In the meantime, if anyone has any doubts so far, I mean, you can put it in the chat box and we'll get to it as soon as you put in, because otherwise there'll be too many doubts at the end of it. So we'll try and clear doubts as and when you ask them.
Sorry, I'm just going down. Right. Okay. So we'll move on to how we interpret a culture report. Now, this is something that unnerves most surgeons as well as physicians, that you have a culture report and you've tried so hard to get it, but what do you do with these susceptibles, resistance, intermediates? How do you analyze them? Which one do you choose from? How do you make these choices? Question is, how does the microbiologist or now the automated culture machine decide if a drug is sensitive or resistant or intermediate for a particular bug? How do they give you these values? So there are various methods in which this is done. This is an age-old method that is still used in many labs across the country today. And for a lot of bugs and drugs, it's still validated. It's called the disc diffusion method. They grow the colony of organisms on this Petri dish. So these lines, these opaque sort of grayish lines are the colonies of organisms growing in culture. Then you have commercially available antibiotic discs, which are sold, which are commercially available standardized discs with a certain dosage of antibiotics. When you put the antibiotic disc, if you find that there is no inhibition around it, there's no clear space that forms around it in 24 hours or 48 hours, a stipulated period, then this antibiotic is resistant to this colony of microbes. These, as you can see, have clear zones of inhibition around them, all these. How do we decide whether this zone of inhibition is susceptible or not? So there is a particular, if you go to the laboratory, you will find them with a little ruler calculating the diameter of this circle. And then according to a particular calculation, they will tell you whether this antibiotic is susceptible for this microorganism or not. So the diameter of the zone indicates the sensitivity. So this is a disc diffusion method or the diffusion gradient method. The other method, which is more popular and accepted now, is the minimum inhibitory concentration. Here you have a colony of organisms which grow in microwells. These are little plates called microwells. They may actually be done manually, where you put little colonies of organisms and then you actually introduce various graded concentrations of an antibiotic. So you're putting 0.5 micron, 1 micron, 2 micron, 4 micron, and you are seeing at what value the organism's growth is inhibited or absent. And that gives you your minimum inhibitory concentration, or MIC. So here you can see that the MIC for this antibiotic against this colony of organisms is 4 micrograms per ml. All right, this may be done either manually in a lab, or now you have automated machines that do this for you. You just have to put in the sample. So as I just mentioned, this is application of the antibiotic concentrations which allow us to get a minimum inhibitory concentration. So when they say MIC, this is how they get it. So these are the two methods we have just discussed. So now you have cultures like this. You can see there's a Pseudomonas here, which has varying susceptible, intermediate resistance, various MICs mentioned on the side. Here you have a Pseudomonas which is pan-resistant, nothing sensitive, nothing intermediate. What exactly is this MIC telling you? Yeah, 128, 128, 64. How do I decide this? What does it indicate? The MIC is basically the lowest concentration of a drug, as we saw in that slide before. The lowest concentration of a drug that inhibits the growth of an organism in a laboratory setting. So over there you saw we put 0.5 micron, 1 micron, 2 micron, and at 4 microns it was inhibited, the lowest concentration. Now this value is unique not only to the isolate in question, but also to the particular bug being tested. So the in MIC for piperacillin tazobactam over here is 128 for this specific Pseudomonas aeruginosa. But for this Pseudomonas aeruginosa, the MIC is less than 4. So the MICs will vary for a drug, for a specific drug, based on how susceptible the organism is. Now, how does the microbiologist or that automated machine decide that this MIC of 4 over here, is it sensitive, is it intermediate, or is it resistant? On what basis is this laboratory telling you that 4 is susceptible and 128 is resistant? There has to be some rationale to this. That's where we come to the term breakpoint. You cannot estimate, you cannot analyze, you cannot interpret an MIC without understanding what a breakpoint is. The breakpoint is a gatekeeper. Remember it as a gatekeeper for antimicrobial use. It's a value that determines whether the organism is susceptible, resistant, or somewhere in between, what we call intermediate. These are set values. It's not something that's decided in your lab. A lot of research, a lot of study goes into it, and these are set values which are given by international regulatory guidance bodies like the American CLSI or the European UCAST body. So every lab has to subscribe to these bodies, and the body will send them the breakpoints for various organisms. And then they use that as a reference when they give you a culture report. So they are even programmed into the instruments, into the automated instruments like your Vitek machine or whatever, to give you an automated interpretation. How is the breakpoint determined? Okay, fine, the regulatory body determines the breakpoint, but how do they do this? Very simply, we can't get into great details of that. They look at how various patients and hosts response across the world. What are the responses? What are the clinical outcomes to different drugs at different concentrations, both in a laboratory as well as in a real world setting, on the basis of which they decide that at a standard dose of a drug, at this breakpoint, anything below this is susceptible, anything above this is resistant. So it depends on several things: the host, the clinical outcomes, the drug dose, the site of infection. Site of infection, you'll ask me. Yes, the same drug has different breakpoints. For example, Streptococcus pneumonia has a different breakpoint for sensitivity when you are looking at a blood isolate or a sputum isolate, and a different breakpoint when you are looking at a isolate of CSF for meningitis. So even the site of infection alters the breakpoint. Having said that, breakpoints are not set in stone. These are not things that can never change. They are often revised by the regulatory body. There's new pharmacokinetic data, dynamic data that suggests that the breakpoint is too high or too low, and the response to this breakpoint is not perfect in the real world setting, so they will change it. If they identify novel mechanisms of resistance for a particular antibiotic, definitely the breakpoints will change. And if there's new data to suggest that there's poor clinical response, breakpoints will change. All right. We know that this is what we call our pharmacokinetic, pharmacodynamic profile for various antibiotics. Some antibiotics need a lot of concentration to be effective. Some antibiotics need a good period of time to be effective. Time or concentration above the given break point. So the break point is the critical point that decides whether your therapy is going to be successful or not. So now let's try to apply what I'm just saying. Yeah, so we have an 85-year-old lady. She's diabetic. She has chronic kidney disease, congestive heart failure. She's had a bilateral knee replacement 18 days ago. And now she develops pain, warmth, swelling over the right knee. She's got fever. She's got leukocytosis. So really, she has a lot of problems here, elderly comorbidities. She's got this early prosthetic joint infection. And her right knee aspirate is now showing methicillin-resistant Staph aureus. All right. She's unfit for a surgical procedure. Why am I saying this is methicillin-resistant Staph aureus? You have oxacillin resistant. Oxacillin is your marker of methicillin resistance. Yeah, it's your, we don't use methicillin in practice. It's just a laboratory sort of parameter. But what we do use are the oxacillin derivatives, cloxacillin, oxacillin, all that. So oxacillin resistant. And to confirm this, we use a cefoxitin screen. Most good laboratories, before they tell you that an isolate is methicillin resistant Staph aureus, will always do a cefoxitin screen. Cefoxitin screen helps to, as Dr. Aditya once made it very simple for me to explain. He said it wakes up the sleeping MEK-A gene, which is responsible for methicillin resistance. It's a particular genetic phenotype of this organism, and cefoxitin screen wakes it up. So this is a confirmation of it. So this is a MRSA. We can see various resistant drugs, various drugs which are sensitive: clindamycin, linezolid, daptomycin, teicoplanin, vancomycin, rifampicin, lots of others. Lots of things that are susceptible. I've just chosen a few to highlight. So among the susceptible antibiotics, which one will you choose? Should we throw this open and let, you can even put it into the chat. I'll look at it from there.
I think Aisha, please explain.
I'll explain?
Yeah.
Okay, all right. So which one would you choose? Would you go with clindamycin? See, the MICs are given over here. You can look at the MICs if you want and decide. This one is 0.25, this one is 2, this one is less than 0.5, 1, 0.03 for rifampicin, such a low MIC. Is that going to be my drug of choice? Question is,
answer in chat box, rifampicin, but she has CKD, so he'll give clindamycin.
Okay.
This is Dr. Gandhi.
Okay.
And Dr. Suranjan Nag has said that he'll give Dapto.
Okay, let me see. Dr. Akshay KS is saying linezolid. All right. So Dr. Nag has chosen Dapto. Again, low MIC. Linezolid has a relatively higher MIC. But my question to all of you is, can we compare the MICs of different drugs for a particular bug? You remember what I just told you 2 slides ago? That the MIC is a personal code. It's specific to one bug, specific to one drug for a particular strain of bug. You cannot compare the MIC of clindamycin to that of linezolid to that of daptomycin. Sorry, I have a screen that seems to be stuck. Just give me a minute.
Dr. Nag has said that only MICs don't decide.
You're absolutely right. You're absolutely right. There's a lot more to it. But here I'm asking you based on the MIC.
So
sorry, I'm just going to have to.
Please go ahead.
I'm just going to have to stop and come back again because my presentation is stuck. Let me just try again. No, we started from somewhere. Sorry, just bear with me a minute. Okay, we are here. Can you see my slides?
Yeah,
You can.
we can.
All right. So a good lab should not just give you the MICs of the for the drugs, for the various drugs. They should also give you the breakpoints, the sensitivity breakpoints, intermediate breakpoints, and the resistant breakpoints. So if we were to take a report like this, you can see again, this is a methicillin resistant Staph aureus. You can see now that clindamycin is sensitive with an MIC of 0.25. And you can see that the sensitive breakpoint is anything less than 0.5. So this is, half of what the breakpoint is. So it's way within that. So it's a good sensitivity. Similarly for daptomycin, which is 0.5 and 1 over here. You can see rifampicin is much lower. As somebody pointed out, Dr. Gandhi, I think, pointed out right in the beginning. Tigecycline. Let's look at tigecycline. Yes, we know that it's a drug that can work against MRSA. Why do we have nothing here? Because sometimes these regulatory bodies feel from their data and all that there are no breakpoints. So there are no breakpoints for tigecycline. We know that yes, it does work for most MRSA isolates, but a laboratory cannot reliably tell you whether it's sensitive or not, because there are no sort of fixed breakpoints for it that have been recommended for this organism. Look at teicoplanin. Now look at this. Less than 0.5 and you have a breakpoint of 8. Look at the ratio over here. So if we come back here, among the susceptible antibiotics, if you had to choose on the basis of breakpoint alone, then teicoplanin really has the lowest breakpoint to MIC to breakpoint ratio, which is 0.5 to 8, which is 0.06. So if I have to decide on the basis of breakpoint, I can never compare one drug with another. I must look at the drug with respect to its breakpoint for that particular organism. All right. Rifampicin, yes, has a very low MIC, and I will come back to rifampicin shortly. Okay, so before I go any further, Dr. Agashe, sir, Aditya, would you like to now start your thing?
No, I think you go ahead.
Shall I go ahead?
Yeah,
And then
please.
we'll come back.
Please.
Okay. Now, I think Dr. Nag pointed out that breakpoints alone don't decide. And he chose daptomycin for this lady. There are no right and wrong answers. There is no black and white over here. There is always room for differences in opinion. And I agree with him entirely that it really isn't that simple. If it was that simple, you wouldn't need a specialist or a physician looking at it. The lab would tell you. So what are the other things that we need to take into consideration when we're choosing the antibiotic? Number one, what kind of patient are we looking at? Are we in an outpatient setting? Has this patient walked into my clinic stable with an infection? Am I looking at a patient who's in the hospital, who's admitted, yet stable with an infection? Or am I looking at a really sick patient with high fever, toxic, leukocytosis, septic shock, in which case I might want to use a different kind of antibiotic, a cidal drug, one that rapidly achieves concentrations, perhaps one that has an antitoxin effect. What is the site of infection? Am I looking at a bloodstream infection where most of my drugs will achieve levels which are documented in an in vitro setting? Or am I looking at an infection which is quite different, something that's in the soft tissue, something that's in a sanctuary site, bone, synovial fluid, CNS? Is source control possible in this particular case? Is it not possible? Is it partial? Is it complete? What is the role of biofilms? Dr. Agashe wanted me to touch upon that, and I certainly will. What sort of implant is inside? What is the nature of it? What is the extent of it? Do we have other vascular devices, catheters, pacemakers? What is the potential for drug toxicity or interaction with other drugs? We must remember that in orthopedic infections, we don't give antibiotics for 5 and 10 days. Sometimes we give them for weeks and months. So the toxicity, interaction, cost are all very important things to bear in mind. And finally, what is the duration of treatment? What is the cumulative toxicity given the duration of treatment, the cost, the ease of administration? So let's start with our first point, all right? And I mean, these are really all the things that we need to target if we want to hit bullseye with our antibiotic choices and our regimens. So let's start with our patient, okay? And as we just spoke, if we have really sick patients, unstable patients, we might want to consider bactericidal antibiotics. So what are our bactericidal agents traditionally? If we're talking about gram-positive drugs for organisms like strep, staph, enterococcus, what are our bactericidal drugs? Most of the penicillins are bactericidal: cloxacillin, flucloxacillin, cefazolin, cephalexin, daptomycin, as was pointed out, good bactericidal option, but at high doses. Daptomycin at the regular 6 milligram per kilogram per dose is not good enough for a bone infection. For bactericidal activity of daptomycin, you need a bone penetration dose, which is much higher, 8 to 10 milligrams per kilogram per day. What about the methicillin-resistant organisms? Drugs, vancomycin, teicoplanin. Again, daptomycin is the only drug among the gram-positive drugs that works equally well for methicillin-resistant isolates as well as methicillin-sensitive isolates. These drugs work solely for methicillin-susceptible isolates, whether it's methicillin-susceptible Staph aureus or methicillin-susceptible coagulase-negative Staph or cons. They do not work for the MR isolates. What about the glycopeptides like vancomycin, teicoplanin, other drugs? Do they not work for MSSA? Of course they do. But there are ample studies to show that they are inferior to these drugs for MSSA, except for daptomycin and now the 5th generation cephalosporin, which I alluded to earlier, ceftaroline, which would work equally well for both MRSA as well as MSSA. What about drugs for gram-negative organisms? What about the bactericidal choices we have here? Again, the cephalosporins, the beta-lactamase inhibitors, which we discussed earlier, carbapenems, fosfomycin. These are for the Enterobacteriaceae. Enterobacteriaceae is the family of gram-negatives, which includes E. coli, Klebsiella, Enterobacter. The most important ones are E. coli and Klebsiella. Then we have non-fermenting or different kind of gram-negative bugs like Pseudomonas. We know that fluoroquinolones like ciprofloxacin is an excellent bactericidal agent for Pseudomonas or for any other gram-negative which is sensitive. Cephalosporin, 3rd generation cephalosporins like ceftazidime, monobactam drugs like aztreonam, BLBLI like piperacillin tazobactam, and among the carbapenems, ertapenem is not active against Pseudomonas, but meropenem, imipenem are excellent choices. Acinetobacter, sulbactam, ampicillin sulbactam, all bactericidal. Colistin, polymyxin B, aminoglycosides, all bactericidal for gram-negative organisms. So what are the static drugs then? What are the bacteriostatic drugs that one should use with caution in a patient who is sick and unstable? Among the gram-positives, clindamycin, linezolid, trimethoprim sulfamethoxazole or Septran, doxycycline, chloramphenicol, aminoglycosides for gram-positive agents are static. So again, not cast in stone here. Aminoglycosides are sidal for gram-negative agents, but static for gram-positive agents. So aminoglycoside is not a drug of choice for Staph aureus, even though it may be sensitive on a culture. What about the static gram-negative drugs? Among the static gram-negatives, the most important group are the tetracyclines, minocycline, tigecycline. They work very well, but we must remember that we have a really sick patient, unstable patient, poor source control. We should use these drugs with caution because they're static. TMP, SMX, Septran would be static for gram-negatives as well. So as I pointed out with the aminoglycosides, you can see that a drug which may be cidal for one set of organisms is static for another. Linezolid is cidal for the streptococci, but static for staph and enterococci. Similarly for vancomycin with strep, staph, and enterococcus. Similarly for some of the antifungals as well. So bactericidal drugs will have rapid killing. They will work well when there is a high bacterial density, where there is a very large inoculum. Focally immunosuppressed sites like the bone, the CNS, where there's poor vascular supply, necrotic tissue, and a difficult source control. And definitely bactericidal drugs are the choice in infections like endocarditis, meningitis, osteomyelitis, or in immunosuppressed patients, especially febrile neutropenia. Of course, optimal dosing, pharmacokinetics, and tissue penetration all complement the bactericidal activity. So let's take this case as an example of what I've just shown. So we have a 71-year-old gentleman who was an uncontrolled, this was a very recent case that I was called in to see, uncontrolled diabetic. He had a closed fracture of the left femur just 4 days prior, and that was managed conservatively at home. Nothing was done for it. He was admitted 4 days later with high fever, encephalopathy, hypotension, leukocytosis of 34,000, thrombocytopenia, and coagulopathy. Looking at all this, the fact that he was on supports in the ICU, you can clearly see over here that there is a lot of sort of redness, there's a cellulitis, and you can see the characteristic ominous skip areas of necrotizing fasciitis, which is corroborated on the CT scan, showing you, tissue with a lot of air in it, necrotic tissue and necrotic necrotizing fasciitis. So I've kind of given away the diagnosis over there. It's really a no-brainer. But what antibiotic or antibiotics would you select in such a patient? Again, you could put it onto the chat and we could just take it from there. We don't know, the cultures have gone, everything has gone. We don't have any clue as yet, and we're just trying to select an appropriate antibiotic for this patient. We don't know what the source is. He was at home. He didn't seem to have any other symptoms before the fever developed. He just had a closed fracture of the left femur. We don't know if that's related also. Does anyone want to go? Piptazo, broad spectrum. Okay, excellent. One is Metro plus Piptazo. You want to give an anaerobic cover as well. All right. I agree with Piptazo. This patient has not been in a hospital setting. Patient has been in the community all this time, and no reason, hasn't really had a lot of hospital exposure or anything in the last month. Yes, this is necrotizing fasciitis. Piperacillin with amikacin and Flagyl, which would be metronidazole. Okay. I guess Dr. Aniket is trying to cover Pseudomonas with this combination. Thinks that 2 gram negatives are required. Okay, so let's move on. We have yeah. Okay, so this seems to give us a problem if we stop and sorry. Okay. So I agree with your choice of piperacillin tazobactam. However, we must remember that in cases where you have necrotizing infection in really sick patients, we want a drug that also has an antitoxin effect, and that's where I brought this in. So in our skin and soft tissue infections, in our bad necrotizing pneumonias, in addition to the regular broad spectrum that you would add depending on whether your patient has healthcare exposure or not, a protein synthesis inhibitor which offers some degree of immunomodulation is something that is desired. And what are these protein synthesis inhibitors that offer antitoxin effect? We have clindamycin, we have linezolid, we have tigecycline, right? Piperacillin tazobactam does have some degree of anaerobic cover. It may not cover anaerobes to the extent that meropenem does. We must remember that if we give something like meropenem, you don't need an additional metronidazole. Meropenem is good enough. It covers over 95% of all gram-negative anaerobes, if not more. But with piperacillin tazobactam, if you're worried about anaerobic cover, yes, perhaps metronidazole could be added. If you use something like clindamycin, it has excellent antitoxin effect as well as anaerobic cover. Linezolid, of course, is purely gram-positive, does not have any anaerobic cover, but excellent antitoxin effect. Tigecycline is broad spectrum, covers a wide range of gram-positive and gram-negative, as well as the anaerobes, and also has very good antitoxin effect. So tigecycline is a good choice for skin and soft tissue infections. Should not be used alone in a patient who's really sick because it's a static drug, but offers excellent antitoxin effect. The downside, the flip side of tigecycline is because it's so broad spectrum, gram-negative, gram-positive, anaerobic, it really damages the microbiome. So it really damages the human normal microbial flora. So we use it in select situations. We don't use it across the board. Moving on to the next thing, the site of infection. All right, so today we are discussing bone and joint infections. Let's look at our penetration. So if we look at the gram-positive organisms, and we look through all our gram-positive drugs, really, most of them have good penetration both into the bone as well as into the synovial fluid, except for fluclox or cloxacillin, which is poor in the bone, poor in the synovial fluid, and vancomycin, which is to some extent moderate in the bone. Gram-negatives, again, except for colistin or polymyxin, which really has very poor bone penetration, all the rest are quite good. The fluoroquinolones like ciprofloxacin are particularly excellent in terms of bone penetration. So let's come to this culture report now. All right, we have an E. coli, we have a Proteus over here. You have an E. coli that is quite resistant. We'll come to, the hierarchy of resistance in a few slides, but here I'm just showing you something. What I want to bring to your attention here is colistin or polymyxin. We just spoke about colistin, polymyxin having poor bone penetration. Here it's probably one of the only drugs that is intermediate for this E. coli and resistant for Proteus. So if we had to choose one drug, okay, we could choose something else for this Proteus, but what could we choose for this E. coli over here? So we've asked for our colistin MIC because they've told us it's intermediate. And they've told us that the MIC is less than 0.25. We'd have to find out what the breakpoint is to understand, what the sensitive range is. But this is clearly coming in the intermediate range. What does that mean? What does intermediate mean? It means that if you were to use colistin for this particular isolate, your treatment success is more likely if you increased your dose, if your dosing regimen is changed to sort of improve the pharmacokinetics, or you have an infection at a site where the antibiotic concentrates effectively, which is not so over here. Colistin does not concentrate effectively in the bone. It barely reaches 25% of the plasma volume in the bone, that too with very variable pharmacokinetics. So it would be difficult in a drug that has so many toxicities to increase the dose, to change the dosing regimen, and to have optimal drug concentration. Whereas if we continue to use it in the same dose that is recommended for sensitive categories, or we use it at a site where the antibiotic does not concentrate, we're more likely to be fraught with lack of success with this drug. So I'm just trying to bring to your attention what intermediate means on the report. If you can use it in a place where it effectively concentrates at a higher dose than what is recommended, then you could get away with that antibiotic. So what would you start in such a patient for whom colistin is intermediate? Would you give colistin polymyxin alone? We just discussed it doesn't make sense to do that. Would you give it with imipenem? Would you give it with fosfomycin? None of the above. Would you give something else? So that brings us to combinations. What do we have in favor of combination? Various things. We know that in the bones, in the synovial fluid, often we have suboptimal plasma concentrations with accepted doses. We have major dose limiting adverse effects, especially with these colistins. They cause nephrotoxicity, severe neurotoxicity. And we also have synergy, proven synergy, in vitro synergy with other drugs like carbapenems, tigecycline. The polymyxins or colistin belongs to the polymyxin group of drugs. The polymyxins actually act as a carpet bomber. They drill holes into our bugs and then they allow the other drugs to enter. So we have sort of favorable things in, various things in favor of a combination. What goes against a combination? We have no evidence in support of combinations from our gold standard randomized control trials so far. We know that there's a diverse group of critically ill patients, and so it's very difficult to do RCTs on such patients. Give one patient monotherapy, a dying patient monotherapy versus combination therapy. It's not ethical to do such a study. And we have different sites of infection that we cannot apply across the board. So expert opinion is that we favor combination therapy for bone infections, for difficult to treat infections, for infections where source control is incomplete or not possible. And that combination may be with a carbapenem, fosfomycin, tigecycline based on various other parameters and what you have in your susceptibility. So we clearly saw that colistin is not the final word. Yeah, it's not the Tesla of antimicrobials at all. And if we were to look at the same report, we will see that there is something called intrinsic polymyxin resistant. And even among the gram-negative organisms, why was Proteus given as resistant? Proteus is resistant because this entire group of gram-negative organisms, including anaerobes and gram-positive organisms, are intrinsically resistant to polymyxin. So for all these gram-negative organisms, polymyxins can never be used. Colistin, polymyxin can never be used. They are genetically, intrinsically, inherently resistant. So what did we do for this patient? There are newer advances in microbiology. You can do a molecular test for these kind of pan-resistant organisms where everything is resistant. You can ask for what we call an expert carba. This is a genotypic test to see what resistance pattern you may have. What is the carbapenemase production? What is the enzyme that is causing the resistance? And based on the enzyme that is causing it, this is a new choice of antibiotics that may be chosen. Clearly, this requires help from your microbiologist, physicians, intensivists, ID specialists. So, are the newer fixed drug combinations the answer? We have a lot of newer fixed drug combinations in the market. Are these really now the stealth weapons that we can rely on? Like I said, we had a ceftazidime avibactam over here. What do we know about the others? We have quite a few of these. We have ceftriaxone, tazobactam. We have cefepime, tazobactam. I've given some of the brand names here, Montaz or Geos. We have ceftriaxone, sulbactam with EDTA combination, which is in vitro supposed to destroy some of the carbapenemase that is known as Eloris. So would these be rational, good choices in these pan-drug resistant organisms that we sometimes, not sometimes, but we come across more often, unfortunately, nowadays? We must remember that unfortunately, we don't have drugs that are necessarily passed by the US FDA over here or any other strong regulatory body. The dose ratios for these drugs have been selected. So when you do the ratio of ceftriaxone to tazobactam or some of these drugs, they have not been selected on the basis of any scientific studies or basis. They've just been selected on the basis of convenience. There's no in vitro efficacy data. Forget in vitro, there is no phase 1, phase 2, phase 3 clinical studies for these combinations. And there's no scientifically developed product-specific antimicrobial susceptibility test method. By that, I mean no laboratory is authorized to tell you whether these drugs are sensitive or resistant for a particular organism, because there is no breakpoint for these. It has never been tested, it has never been regularized, and there is no breakpoint. So in fact, recently we have made a strong move in our hospital at Hinduja to stop stocking irrational antibiotic combinations which are not sort of accepted or authorized by a regulatory body, because we have no evidence of their proof of activity. And there's a similar lack of efficacy data for oral combinations like Zifi Turbo, which we often see used, which is a combination of cefixime with linezolid. Nobody knows whether this combination is synergistic, antagonistic, and it's really a scientifically irrational combination. Let's move on to the next point. Source control. Role of biofilm. Let's try to take both these points together. Let's come back to the same patient that we were discussing earlier. She has a prosthetic joint infection with MRSA. She's unfit for a surgical procedure, hence no source control is possible. So we have chosen, I think last time we chose the bactericidal agent teicoplanin. Somebody said daptomycin. Fair enough. Okay, Tyco, Dapto, on basis of various reasons. We must remember that when we choose any of the drugs, as I pointed out, daptomycin in a higher dose, teicoplanin also has a higher dose for deep-seated infections like osteomyelitis. It is 12 milligram per kilogram per day, unlike the regular dose. The regular dose has a loading dose of 400 milligrams 12 hourly for 3 doses, followed by 400 milligrams 24 hourly. For bone and joint infections, it would be 800 milligrams 24 hourly. Please remember that. Step down is not advised when you can't do surgical procedure, when there's no source control for at least 6 to 8 weeks. In my experience, as much as I want to step down for a methicillin resistant staph, I find that the oral drugs are sometimes not tolerated as well as the IV because they all have their set of adverse effects, toxicities. The patient actually comes back and says, I'd rather go ahead with the IV for a longer period. And that works well. Duration of treatment, IV for 6 to 8 weeks in such a patient, 6 months of oral agent with good bioavailability. All right, we've got a knee replacement over here, and followed by an indefinite chronic suppressive therapy. Now, what are the oral options that I can move on to? This patient has finished 6 or 8 weeks of IV teicoplanin. I have levofloxacin, which is intermediate. I may not go for that. I have clindamycin, linezolid, tetracycline, rifampicin, TMP-SMX or Septran. So I have to keep these things in mind when I'm choosing an oral agent. What is the bioavailability of that oral agent? Does it undergo extensive first pass metabolism in the liver? In which case, by the time it reaches a site of action, the concentration will be very poor. So I want a drug which has good bioavailability, like clindamycin. Linezolid has good enough bioavailability. Fluoroquinolones, if the fluoroquinolones are sensitive, they have excellent bioavailability orally. Toxicity, that's something that I need to keep in mind. I know that whereas linezolid is excellent, it has its own set of problems. I have to keep cost in mind. Can I begin with oral treatment? There is the dictum, the standing dictum that for osteoarticular infections, IV is the go-to to begin with. And that's pretty much the Bible and the Mecca of everything that we've been taught. But is that being questioned? Yes, it is. And we've had recent papers, one published in the NEJM, which was perhaps the first RCT of its kind on a large number of patients. It was a very inclusive trial involving both native, prosthetic joint, implant infections, vertebral osteomyelitis, where receipt of appropriate culture-based oral or IV antibiotic was given within 7 days of surgery, regardless of the organism. So that was a very important caveat. These were for very early infection, within 7 days. Treatment failure was about 14.6% in the intravenous group and 13.2% in the oral group. Really no statistical difference over there. And they almost concluded that there was no real inferiority when it came to the oral group as compared to the IV group. But again, very important here that they were talking about very early infections after surgery. All right. And if we look at this chart, if the organism was not, if the pathogen was not identified, there was definitely a trend towards sort of better outcomes with IV rather than oral. If metal was retained, if hardware was retained, again, it leaned more towards IV than oral. Of course, everything is crossing the midline, so nothing is statistically significant, which tells us that we still need a lot more studies, larger studies, to corroborate whether we can get away with oral. As I said, if you have an organism which is exquisitely, you know the organism, you've been able to take out the hardware, you're happy with your source control, you have a drug which has excellent bioavailability like a ciprofloxacin for Pseudomonas, then yes, we have gotten away with starting off with an oral therapy itself. What about organisms? So this is what Dr. Agashe asked me to touch upon, and I'm doing that over here. Which are the organisms that are notorious for forming really effective biofilms and existing, coexisting, reproducing, and producing mayhem within those biofilms over a long period of time? So Staph aureus and coagulase negative staph is really the leader of this group. Enterococci, streptococci, Pseudomonas, E. coli, practically most of the important organisms, including the non-tuberculous mycobacteria and candida, can all form very good biofilms. And biofilms, as Dr. Agashe pointed out, is really all about strength in numbers. They lie quiescent, they lie dormant, they're very resilient and hardy organisms. They live under all sorts of unfavorable conditions. They communicate effectively with one another within the biofilm and even with organisms in other biofilm areas of the body. So they have a very, very efficient and very sort of advanced means of communication. And they even exchange tips on survival and resistance. So really these bacteria outsmart us in every sense. So coming back to that same culture report, the same case and biofilms, we have a prosthesis in situ. We're going to have to deal with biofilm. And we have a lot of data telling us that in gram-positive infections, especially staph infections, where you've retained the implant, rifampicin must be given as adjunctive therapy in combination, never alone, regardless of how low the MIC is. Never alone, always in combination with other active Staph aureus agents. And why? Why in combination? Because it rapidly develops resistance in the setting of monotherapy. So in fact, not only in combination, but allow the other drug to act for several days after debridement, after antibiotic initiation. We wait for almost 2 weeks before we start the rifampicin in some cases. So we really wait for the bioburden to come down. The dose is different from the anti-tubercular dose. We give 300 to 450 milligrams twice a day of rifampicin. Duration of rifampicin, regardless of the other antibiotics, should be at least up to 6 weeks. And of course, we have to watch hepatotoxicity and drug interactions with other polypharmacy. What about the potential for drug toxicity or interactions with other drugs? I touched upon this. We know rifampicin particularly is an enzyme inducer. It has a lot of drug interactions with other drugs, and you must look this up, check this up before you use it. Linezolid causes severe bone marrow suppression. Anybody who's on linezolid, we check their CBCs at least once in 2 weeks. It causes debilitating peripheral sensory neuropathy, which I see in my drug-resistant TB patients where we use it for months on end. And the peripheral neuropathy with linezolid can be so debilitating, patient can't sleep at night, and it goes on for months even after you stop the drug. So please, when you use this drug, be aware of this and realize that it can really potentially cause so much grief to a patient. I've seen optic neuritis, fortunately not leading to irreversible blindness, but I've seen optic neuritis with linezolid. Lots of drug interactions, especially with psychiatric medications. So anybody who's on antidepressants, antipsychotics, please be very careful about using linezolid. It can also cause lactic acidosis. You have patients coming with severe abdominal pain, nausea, vomiting who are on linezolid. Remember, lactic acidosis is a possibility. Clindamycin is notorious for Clostridium difficile diarrhea. And I've also seen several cases of severe clindamycin-induced drug rash. Moving on to this very well-known and gaining popularity drug, pharopenem. So what is pharopenem? It's an oral antibiotic that belongs to the penem class of beta-lactams, not carbapenem, penem class. It's quite different. It's a hybrid of penicillin and cephalosporins, and it's structurally very similar to carbapenems. It does have a broad antimicrobial activity against gram-positives, gram-negatives, and some anaerobes. It has been approved for respiratory tract, urinary tract, skin and soft tissue, gynec infections. We also know that in our country, the consumption has increased exponentially over the past 10 years, far exceeding all the other carbapenem consumption in India. This is a slide showing you the same. You can see how much more consumption of pharopenem there is. Caution to exercise. It's often used to treat invasive ESBL and CRE infections. Although efficacy in these cases is not clinically proven, there's no susceptibility testing that can be performed. Again, like the other drugs that I told you about, there are no established breakpoints. It's not approved in the United States or Europe. And of course, when we sharply increase consumption in the community like this, especially when it's easily available and it's an oral option, there is always the potential for cross resistance to the carbapenem. So be careful with this drug. It's really nothing that we have much information about. What about this new kid on the block that has entered the arena? This is the first completely made in India molecule by Vocard. Levonadifloxacin, it's a new generation fluoroquinolone. It's sold under the brand name of Emroc. Again, has a wide spectrum of activity, gram-positive, quinolone sensitive, gram-negative, atypical, and anaerobic bacteria. It's supposed to be active against resistant strains like MRSA, VRSA, various other things. It's supposed to have very good bactericidal action, even when there's high inoculum of bacteria, intracellular environment, pus, necrotic tissue, demonstrates favorable permeation of biofilm layers. It has a good bioavailability, and is supposed to be safer than other fluoroquinolones, does not cause certain arrhythmias, phototoxicity, nephrotoxicity, various other things. So really, all in all, it looks like an excellent package. What is the flip side? We have a DCGI approval for skin and soft tissue infections, for diabetic foot infections with bacteremia. We have some phase 3 multi-center randomized open label trial that was done where it was compared with linezolid and it was found to be non-inferior for the treatment of skin and soft tissue infections. What is the caution with regards to this drug? There is no published study for deep infections or bone infections. Again, because it hasn't met the regulatory standards as yet or whatever, there are no established breakpoints to determine susceptibility. So when you use it, remember that if there are other agents which are susceptible and for which you can prove susceptibility, that leaves you with very little to use this drug if you cannot prove susceptibility in a laboratory. Yeah, and no laboratory can give you susceptibility for this because there is no breakpoint to tell you that the MIC that you're getting is susceptible or resistant. And it's very expensive. It's as expensive as using daptomycin or ceftaroline or any of the new drugs. So I've been a little patient with waiting for more information about this, because when I'm using an expensive agent in a deep infection, patient who's sick, I want to be certain that I can rely on it and fall back on susceptibility. What about duration of treatment? We spoke about. So again, I've gone through all these things with pretty much the same case. We had non-surgical management here, chronic suppressive therapy, which would be indefinite. All right. If we had to choose something which is chronic suppression, going on indefinitely for months and months on end, all right, this is what I've tried to put over here, that this is what we would choose. Something like Sporidex, which is tolerated, not expensive. We know that oral flucloxacin is available, but it's very expensive. Flucloxacillin on a long-term basis has even known to be associated with some degree of hepatotoxicity. So these are things that you keep in mind. You had to choose the MRSA drugs, again, clindamycin. You have to watch for diarrhea, watch for rash, linezolid, doxycycline and its GI disturbances. Fluoroquinolones, your levofloxacin, moxifloxacin are potentially can be used. We have to watch for arrhythmias, watch for other problems with that. Sulfamethoxazole, trimethoprim, or your Septran can sulfur allergies in some patients. Bone marrow suppression is also known with these drugs. So these are the other drugs that you could choose. Ciprofloxacin is a good choice for chronic suppression. Cefixime, clavulinate, all these are drugs that we have used for chronic suppression based on what the organism is, what our cultures are, and how we've managed. Okay. So I'm going to wrap that up with this table, which you can go through in detail later, because for me to read the entire table would perhaps not register at the moment, but just telling you what are the basic durations for antibiotics and some remarks for debridement retention, 1-stage exchange arthroplasty, 2-stage exchange arthroplasty, permanent resection arthroplasty, amputation, and finally, non-surgical treatment. I'll just go back to amputation here, and this is something that we follow. We know that after an amputation, 5 to 7 days of antibiotics post-operatively is adequate if our margins are clear, if there's no evidence of stump infection or sepsis. But what we've been doing of late is collecting cultures both from the soft tissue of the stump as well as the medullary canal. And if the medullary canal of the stump is showing an organism or growth, then we treat it as an osteomyelitis and continue to treat for 4 to 6 weeks to prevent recurrence and stump infection. And that's for non-surgical treatment, like I spoke about, indefinite chronic suppression. So this table is for you to go through later. Okay. So now I'll let Dr. Aditya and Dr. Agashi come in and discuss the surgical site infection.
Thank you very much, Aisha. Excellent, exhaustive talk. Difficult for orthopedic brain to assimilate and understand all this. But what I would suggest the participants that download this talk. I'm sure Dr. Neeraj would send you the recording of this talk and go through this talk at least once or twice before you decide what treatment you would give for your patients. Thank you very much. Excellent talk, Aisha. Thank you.
Thank you.
Will you stop sharing your screen?
Sure.
Now, there are a few questions. Dr. Aditya, will you take these questions? You are muted. Okay.
No?
Yes.
Yeah.
Audible.
Am I audible, sir?
Yes, yes.
Yes, yes.
Okay. So the first question by Dr. Aisha Mohapatra is, if you culture an organism which grows biofilms, then after we start the antibiotics for that particular bacteria, we know there's a biofilm. How do we know it's going to be effective?
So that's what I basically try to emphasize, that as far as possible, we try to sort of get rid of the biofilm. But in certain cases where you can't, you try to add an additional agent which has good biofilm activity, like the ones that I pointed out to in my slide. How do we know? There is no foolproof sort of way of knowing, in vivo whether the biofilm is being destroyed or not. So this is the best you can do.
And we'll cover a bit on that in the debate, Akash sir and me, so that concept will get cleared. What's the tentative time around which biofilms get established after an infection is set in once we do our fixation with a plate or a nail? Is it weeks, minutes, days, months?
Yeah. They're known to develop in a matter of few days to a week, 2 weeks. So you need to be very careful. You try to address a suspected infection with your knife within first few weeks.
Correct. And what sir is saying, we'll be discussing the same in the next module, in the coming modules, where we'll say what is the window period which we have to get rid of that biofilm before it becomes mature, becomes intramedullary, and then even surgery may not help. There's one more question by Dr. Aisha where she has asked, what's the rationale behind 6 weeks of initial IV treatment?
Yeah. So, Dr. Aisha, this is not sort of, across the board. This is for the case that I was talking about particularly, where you're not offering surgery to the patient, there is no source control possible or whatever. In other situations where we know the organism, we are happy with our source control, we have, tried to remove as much hardware as possible or whatever. And we have organisms for which we have oral agents with good bioavailability, you could step down even earlier at 2 weeks. Or even right up front, as I said, if you have a good oral agent like ciprofloxacin, which is sensitive.
So friends, one word we will keep using again and again, and that is source control. That is absolutely vital in most of the cases of orthopedic infections. Antibiotics without appropriate source control they are handicapped. Remember that. And we would discuss that in later modules. Yeah.
And one very, very clinically relevant question by Dr. Subramanya Gandhi is, in case of osteomyelitis or any infection, if we have 2 sensitive antibiotics, why not give both? Why give only one? 1 + 1 is 2, so that's better. Or should we give only one? And that's a very, very clinically relevant question. So we think, why not give amikacin and Ciplox? And for maybe staphylococcus, why not give linezolid and teicoplanin, 1 oral, 1 IV? I mean, 1 + 1 is 2.
Clearly, since you agree, I don't think like a surgeon. It never even crossed my mind. But honestly, I would make my choice based on the best fit for that patient, based on the organism, the site of infection, whatever. And sometimes, yes, there's more than one best fit. There are several that I have to choose from, and I'm spoiled for choice. Yes, we have switched antibiotics in between when there is intolerance, when there is non-availability. But we must remember that the more antibiotics you use, the more you're exposing the human biome to different agents, the more you're selecting resistance, because every antibiotic has its own spectrum. So when they talk about stewardship, when they talk about de-escalation, when they talk about using the least number of antibiotics for the least amount of time.
Okay. So if, for example, to make it simple, if there are 100 bacteria and I give cefazolin, which kills 90, and there is cefuroxime, which also kills 90, if I give both together, doesn't mean all 100 will get killed. They will still stay at 90, so just one is good enough. Does it come down to that?
And they will also kill 90 and 100 of the good bacteria required in your body to prevent further selection of resistance. Yeah, so
Okay.
There is cumulative collateral damage also happening.
Got it. The next question by Dr. Nag is, while on antibiotics, still no clinical response, there is increase in CRP, when and how to take cultures and how to interpret. I think how to take cultures we'll be discussing in one of the talks ahead, and interpretation probably has happened in the previous talk with Dr. Aisha. And how do we clinically, Dr. Aisha, would you just want to summarize your talk for that question?
that there's still no clinical response. That's a question you want me to take. So increase CRP, when and how to take cultures, how to interpret. Right. So honestly, we have to go back to the drawing board. When you feel that it's not working out, when despite everything you've done, you're either on an empiric antibiotic or you've had a culture and it's not working out, your CRPs are increasing, you've got a patient who's in pain, who's not clinically improving, that's when we send the patient back to the surgeon and say, we need new cultures. We stop our antibiotics. That's where we call it a day.
Okay, so I think Dr. Aditya, if you could discuss about taking cultures.
Okay.
Yeah.
Since there were quite a few questions on that, we'll go ahead with
Yeah.
talk.
So the most challenging thing is getting appropriate culture report, getting a positive culture report. Very often, I mean, generally the percentage varies from 10% to 40% negative culture report. So Dr. Aditya will discuss how to maximize culture yield. This is in fact part of our prospective study, which is going on for last about 20 months. And we have had some very good results. So Dr. Aditya.
Yes. Thank you, sir. So a lot of clinically relevant questions for us, and hopefully this talk will answer some of those. We'll cover the other questions after this talk. Now, this is one thing that all of us surgeons are always worried about. Culture, no growth. We've sent everything, we've done everything, and we don't know what bacteria to treat with. And the paper that Dr. Ayesha showed, the study from England, the randomized study, was also very clear that if we don't know the bacteria, the results are worse than when we know the bacteria, because we can give the appropriate antibiotic. So I'll cover on how we can maximize our culture yield, which is one of the most important steps as far as achieving success whenever dealing with a surgical site infection. So when we see this, we know there's a discharging sinus, we know there is redness. We go in and we see frank pus. Of course, there's bacteria. Even if we get a negative culture report later, does not mean that there is no infection. Frank pus means infection, or discharging sinus means infection. Redness, erythema, swelling after an internal fixation, by and large, is infection. Then the question is, why do we end up with this no growth? I mean, what is it that we must do as surgeons to avoid this as much as possible? And in the prospective study that Akash has been talking about, we've been collecting our data. We've had slightly more than 90% culture positivity. By and large, we see 40, 50, 60%, sometimes even lower, but we've had about 91% culture positivity across various causes of surgical site infection, hematogenous osteomyelitis, soft tissue infections in our institute. Now, this talk will summarize as what our journey through the last few years and how we've come up with this protocol to get those results. And it's been a team of infectious disease specialists, orthopedic surgeons, microbiologists, all of us together have come up with this to convert a no growth to a positive culture report. One of the most important things that we must remember is a biofilm. There are antibiotics, there are implants, but we must remember the biofilm, which we, with Agashi sir and Dr. Ayesha, have been mentioning time and again. Why? Because the bacteria become very strong, very smart, and they just go into hibernation. So that's what a biofilm has, sessile or inactive bacteria. When they're inactive, they don't need anything. So the antibiotics will not be able to act on them because they have a safe cover and they're sleeping. They're just dormant. Anybody who's active or planktonic will need something. So the bacteria will be able to act on them. So our idea must be to try and convert the sessile or inactive bacteria, get rid of them surgically, or to convert them into active bacteria so that our antibiotics can act on them. So you must create an ideal scenario to get culture yield. There are 4 very important things. One is the antibiotic-free period. Second is getting the ideal sample, then transporting them in the right medium and doing the ideal tests. All these things will help us get positive cultures in more often than not. So we've divided into preoperative strategy and intraoperative strategy. Preoperative means having an antibiotic-free period where the patient is not on antibiotics communicating with an infectious disease specialist. If not an infectious disease specialist, you don't have access to one, communicate with your physician. Get the appropriate sample collection medium in your operation theater before starting surgery. Otherwise, we're always struggling to find culture media. Get to the ideal sample site, and we must know which tests to ask for. What do we study? Bacteria, TB, fungi? How do we do that? So going to the first one, the preoperative strategy. We must ensure an antibiotic-free period. Now, to highlight that this was a 73-year-old male with a proximal TB osteomyelitis with plate in situ. Patient had a united fracture, was a diabetic, presented with a discharging sinus, raised WBC counts, fever. Because the WBC counts were high and patient had fever, antibiotics had to be started on admission. Otherwise, the patient could have gone into sepsis. The very next day, we went ahead, excised the sinus, debrided, excised all granulation tissue, removed the plate, sent tissues for culture sensitivity. But the culture showed no growth. We've sent enough amount of sample. Intramedullary, extramedullary, multiple samples were sent. Most common, most likely that this patient had to be started on empirical antibiotics, and it was started by us because the patient had high fever and WBC counts. So, I mean, we couldn't avoid that, and that was probably the reason why we did not get any cultures. But if the patient does not have fever, patient does not have severe pain, is pretty clinically stable, which is what we've seen in most of our osteomyelitis. The WBC counts are normal, patient is not in sepsis, or it's not an impending abscess. If it's an impending bursting abscess, then we have to start an antibiotic and go ahead with surgery. Or it's not a surgical emergency like a necrotizing fasciitis. In all these criteria that I've mentioned, we must start antibiotics. Otherwise, we have the risk of losing the patient. If none of these are there, ideally wait for 15 days, minimum 15 days. Some literature says 21 days. So at least 2 weeks of antibiotic-free period. So there's a very, very important story that Agashiza keeps telling me. This is before I had joined Hinduja, and Dr. Rajiv Soman, who was a pioneer in infectious disease specialist, infectious diseases. Dr. Ayesha has learned a lot from him. Dr. Agashi had admitted a patient with infected non-union, had a discharging sinus. Patient had taken antibiotics till the day of admission. A preoperative reference was given to Dr. Soman, and he clearly mentioned in no uncertain terms that please discharge this patient, stop antibiotics, and readmit after 15 days. And for us as surgeons to discharge somebody, stop antibiotics 15 days and come back is unheard of. But that is what was done. Patient was admitted after 15 days and cultures were positive.
Yeah, one more thing about that patient was his cultures were taken in other hospitals twice and both were negative. That is why he insisted that you stop antibiotics and then readmit after 15 days.
Correct. Yeah. So if the patient does not have any of these symptoms, please stop the antibiotics and mention to the patient that if any of these things do come up, fever, pain, then unfortunately, we have no choice. We admit them immediately and operate them. But try and get as much as possible. Even 1, 2, 3 days, if possible, is better than 0. So if possible, stretch to 15 days, which is ideal, readmit and get positive results. And that is how we've been able to get almost 90-91% culture positivity by following this protocol as much as possible. Second is communication, because there are simple clues that as orthopedic surgeons, these pictures that are put up are the history from one patient taken by the infectious disease team. Our history, orthopedic history, by and large, stops in 4-5 lines. We look at comorbidity, site, amount of, the pain, the functional disability, that's it. The simple things and clues that the ID team or the physicians ask are history of travel. That gives us idea of certain infection like Burkhold area. Seawater exposure is seen with Vibrio, addictions. And then they also suggest what to test. Bacteria, TB, fungi, what samples to send, special smears are done in certain cases where they suspect. So those are the clues that we get after communicating with the ID team. When we take up our patients for surgery, the files have one big page which is stuck onto the file in the handwriting written by the ID team as to what tests are required. And this is informed. We obviously know that, but the nursing staff in the operation theater ensure that we have sent it for all of this. So this is the protocol that you may be able to start in your setup. Have a printed paper or a manually written paper. pinned it up on a board in your operation theater. So, I mean, otherwise, as surgeons, it's easy to forget when you're operating what all do we need to send for. So, another important part is the extended incubation. Now, there are certain situations where generally the bacteria are incubated for 3 to 5 days. If there is no growth, the culture is discarded. That's the standard practice across the board. But in certain cases where there is no antibiotic-free period, or it's a post-arthroscopy infection where we are suspecting non-tuberculous mycobacteria or shoulder surgeries like propionobacterium, these are very slow-growing bacteria. These bacteria grow after about 10 to 15 days on extended incubation, or they're cultured for a long time. So in these situations, we or the infectious disease team communicate with the microbiology department of the team in microbiology that please do not discard this culture, retain it, incubate it for a longer period. And then we've had a lot of situations where we've seen bacteria grow on day 12, day 15, day 21. Now, this is separate from tuberculous cultures, which are generally grown for 6 weeks. These are bacterial cultures which are incubated for more than the 4 to 5 days, which is the standard practice across the board. But this has to be communicated to the microbiology department. Now, to highlight that, this was a 45-year-old male, had an infection following arthroscopic Bankart repair, low-grade infection, chronic discharging sinus. We debrided, there was no growth at 5 days. But since this was a low-grade infection for a long time, suspecting propionobacterium or QT bacterium as it is known around the shoulder joint, extended incubation was done. On day 15, the cultures grew Achromobacter dentrificans, which is not a propionobacterium. It's a very uncommon gram-negative bacteria. But because it was so slow growing, it took 15 days to show on cultures, and simple oral antibiotics like Septran was enough to treat this. And this patient had been on had multiple surgeries, multiple antibiotics for almost 2 years and did not respond. A simple thing like growing it, extended incubation, gave us the bacteria, and oral antibiotics along with surgery did the trick over here. Third thing is getting the appropriate culture medium. Now, there is something called a Bactic bottle. It's a brand which is available across various microbiology laboratories. If you're planning a surgery, we must ensure that we communicate with the lab and somebody can just go and collect these bottles. There are 2 types, aerobic and anaerobic. Now, the advantage is the minute we take fluid could be pus, it could be synovial fluid, it could be blood. A lot of times when there's no frank pus, what we've done is we've taken the infected granulation tissue in a sterile container, added 1 ml of saline and taken that aspirate and put it in these bottles. It gets directly injected within the bottle under pressure. That is a culture medium. So as we are operating in the operation theater, the culture media start growing these bacteria. And we can get rapid sensitivity results within 24 to 48 hours. So within 12 hours, we've had the lab call us and tell us a gram-positive cocci is growing. So the antibiotics can be redirected. And within 2 to 3 days, we've had the bacteria with the sensitivity pattern. So that's the advantage because we're inoculating immediately within the theater. And the other advantage is these aerobic and anaerobic bottles are available in 2 types. One is standard and second is called Bactic Plus. Now the plus means these bottles have resins. These resins inhibit antibiotics. So if our patient has been on antibiotic and we've not had the antibiotic-free period of 15 days, which is ideal, then please inoculate the fluid, the pus or the synovial fluid or blood in the Bactic Plus bottles. And that has also helped us increase our yield. So in our study, we've had about 80% positivity with Bactic bottles, and combined tissue and Bactic has given us more than 90%. So it's not that it replaces tissue sampling, but in addition to tissue sampling, Bactic bottles have had a massive role in improving our culture yield. And especially in the last 6 months to a year, we've started ensuring that even if there is 1 ml of deep hematoma, so we take the hematoma from the actual non-union site or medullary canal, aspirate it and send it, because very rarely do we find frank pus. So even a deep hematoma from the medullary canal or the non-union site helps get us the culture yield. And there is these are the sterile leak-proof containers, and they come in various shapes, sizes, and colors. This is what is available in our hospital. They must be sterile in a sterile packet, opened on the operation trolley. We take tissue, even fluid can be put in this, but we predominantly use it for tissues. This picture shows us that what we do is we take our glove paper, we don't discard that, with a sterile marker, we label each side 1, 2, 3, 4. The same thing is labeled on the culture container, so there's no confusion from deep tissue from medullary canal, proximal, distal. At the end of it, we decide what to take, what not to take. Similarly, these can be used for something called as sonication. Now, sonication is basically an ultrasonic machine where our screws or plates, if depending on the size of the machine, they are put in these containers, transported to the lab, and ultrasonically vibrated. The bits of tissue stuck to the implant come out in the fluid, and then that fluid is cultured. So that's how these containers help us. In addition to the tissue, we use it for screws or process. Again, that would depend one on availability of a sonication machine and the size of the machine. The machines that we have at our institute, we can sonicate screws which we remove after our surgery. So this was a 73-year-old male, early surgical site infection following a subtrochanteric fracture femur fixation. We did a radical debridement, excised the implant because it was a frankly infected fixation. Multiple samples were sent in containers. Tissues were sent in containers and pus and fluid in Bactec bottles. A positive sample was seen in only 1 out of 6. Which was that one? It was an aerobic plus bottle because the patient was on antibiotic, and that yielded a multi-drug resistant Acinetobacter. Now, if you remember, Dr. Aisha had mentioned that Acinetobacter is one of the most dangerous bacteria that we are dealing with. Even WHO has highlighted that. If you had not identified this, the chances of failure would have been very high. Targeted antibiotics were given, WBC normalized immediately, patient improved, and that is the importance. This case was shown to highlight the importance of aerobic plus bottles. We sent multiple samples, but only one group. Now, the role of our favorite swab stick. This picture, I think, explains our sentiment towards the swab stick. It should not be used in our surgical site. It should be used for anything but sending tissue samples. This study clearly highlights this. This team sent superficial swabs, and the same patient was operated and a deep tissue biopsy was sent. And then they compared what did the swab grow, what did the deep tissue sample grow. Only 1 in 5 matched. All the others did not match. So swab, when we are operating, why send a swab when there is 1 kilo of pus? And Kamala madam, who's our microbiologist, head microbiology, keeps saying, when you get 1 kilo of tissue and 1 kilo of pus, why send only 1 gram? Send us that 1 kilo. We will decide what to do with it. Do not throw it in the dustbin. Send it to the lab. So that's something which has stayed in our minds. We send everything that we take out of the patient, and we avoid any kind of swab because it's a very tiny thing. And especially if we're taking from the sinus, there's a very high chance that we take the skin commensals and not the actual deep tissue. Coming to the intraoperative strategy, ideal sampling and what tests to ask for. Now, that picture which we showed, multiple containers were kept. So that's specifically because we take it from multiple samples, multiple sites. What we should avoid is taking samples from the sinus tract because that's superficial skin commensals, which will give us a false positive report. So that will actually not be the causative organism. But we must send the sinus tract and the scar for histopathology. There's a very, very rare occurrence, but Prakash has had one case where a chronic discharging sinus had a secondary squamous cell carcinoma, which was detected only and only because the sinus tract was sent as histopathology. So this is our a protocol and a norm. The sinus tract with the scar is sent for histopath. Then we come to the tissue above the implant. We take that as sample number 1. This is just a highlight. You can divide it as per your case. Then once the implant is removed, we may send the screw for sonication. Then comes the biofilm deep to the implant over the bone, between the implant and the bone. We scallop it out in one layer with an osteotome, and that is sent as labeled as a tissue deep to the implant or over the bone. And third comes the non-union site or the medullary canal, whether it's a medullary reaming or the tissue from the non-union site. That's the third sample. That is how we divide samples in, label them separately. If it's a process is like a total hip replacement, we can label it as tissue superficial to the joint, acetabular tissue, tissue around the neck of the stem, femur medullary tissue. That is how we can label multiple samples. As far as dilution and addition, this is a very common thing that we do. Take the container, add 10 ml of saline and send it to the lab, and we get a culture negative report. Again, this is one thing that the microbiologists keep on stressing. The clinically, the logistically relevant point for us to note is if we are in a place where the lab is accessible, within the same day, do not add anything to the sample. I'm talking about cultures. Do not add anything. If we know that we're operating late in the night or the lab is not close by and the sample will be sent the next day, just add a few drops of saline, enough to keep the sample moist. But try as much as possible to send the sample on the same day, because the longer we wait, the lesser the chance of the culture to yield something, because the bacteria keep drying. I mean, they don't have an active environment to feed on. They are outside the body. The chances of culture yield go down as we keep on delaying the sampling process. For histopathology, formalin is a standard. The amount doesn't matter because it's not a culture yield. So for culture, same day, do not add anything, not even saline. For processing the next day, just a few drops of saline. But don't make the mistake that a sample is floating in a container of saline. That's the last thing that we want, because all the bacteria get diluted and the chance of getting a culture yield go down significantly. Now, the most important, what do we ask for? We're coming to that. Let's see this case, 78-year-old with an early surgical site infection following a hemiarthroplasty. Multiple debridements were done elsewhere. A cement spacer was put, but still had a discharging sinus in spite of targeted antibiotics. The cultures had grown carbapenem-resistant Acinetobacter. Ceftazidime maveactin was given, which is the drug of choice, which is a new antibiotic and works very well. But the infection was persistent. So we went in again. This is when the patient presented to us. We went in again, excised the sinus, removed the spacer, debrided the acetabulum, and on the right-hand side, you can see multiple samples were sent. Synovial fluid, aerobic, anaerobic bottles were used, tissue from the acetabulum, tissue from the medullary canal, and multiple samples were taken. Now, the ID team in our hospital does a preoperative analysis to gauge the potential pathogen in every case. I mean, they give a list. These could be the potential pathogens. These are guesses, scientific guesses, but we avoid any presumptions. What do we ask for? And that was asked, same thing was done in this case. We asked for smear, that's gram, AFB, and fungal smear, aerobic and anaerobic bacterial culture, fungal culture in every case, gene expert ultra in every case, TB MGIT culture, and histopathology. Yes, it may sound funny when it's a surgical site infection. Why think of TB? There is an entity called non-tuberculous mycobacteria which can get picked up on various tests. We've had cases of mixed bacterial and tuberculosis infections where we didn't even suspect tuberculosis. It may be few and far in between, but unless we test for it, we'll never know. And those are some of the reasons for failures in some cases. And what did we find in this patient? Because of sending for everything, fungi, and not just one fungi. It grew Candida parasilosis and Candida auris from various sites. And the antibiotic treatment is completely different for these fungi. Now, the question that all of us ask, and I mean, this is true even for us at Hinduja, we face this issue where patients, the cost for sampling varies from 2,000 rupees to 10,000, 15,000 rupees per sample. If we ask for bacteria, fungal, TB, MGIT, gene expert, histopathology for each sample, and there are 3-4 samples, the cost gets enormous. So we do give an estimate of 20,000, 30,000 rupees over and above the general charges that a patient would face for a surgery for an infection. So what we can do is convert these 5 multiple samples, but initially when we debride, label them as 5-6 different samples, combine them into 2 samples, or if we have 3 samples, combine them into 1 or maybe 2 samples, but ask for all the tests. So if we combine 5 into 2, at least we are sending appropriate tissue. But let's not guess the bacteria or guess the fungus. Like in this case, although a bacteria had grown, it was the fungi that was missed, and that fungus grew from the acetabulum and the femur. And once those antifungals were started, patient settled clinically. So let's not try and guess the bacteria. Ask for everything, limit the number of samples. Literature says 5 to 6. Yes, that's very difficult to do in our scenario. And that is what we have done at our institute as well. We combine them into 2 appropriate samples, because the cost of no growth and the cost of recurrence is far, far higher than cost of asking for fungal, bacterial, and tuberculosis. So these are the simple things that we must avoid. We must avoid empirical antibiotics till debridement, given antibiotic-free period. Avoid assumptions about the causative pathogen. So we must test for fungi, non-tuberculous mycobacteria. Let's not forget the role of histopathology, especially in tuberculosis infection, both non-mycobacterial, non-tuberculous mycobacteria, and tuberculous mycobacteria. And even in fungi, the histopathology and smear plays a big role. fungal infections get picked up on smear within 12 hours, and we know that we are dealing with a fungus. Communicate with the ID specialist, avoid superficial swabs, get the appropriate samples. So antibiotic-free period, communication, appropriate sampling, getting the right containers, and asking for the right test. These are the protocols. They're simple, but extremely effective in converting our culture positivity from 40% to say close to 90-91%. Thank you.
Thank you very much, Dr. Aditya. I'm sure the culture yield would certainly increase in hands of people who are attending. Now, if there are any questions, there's one question: in view of source control, mucoplating get infected, then when should we convert to open and remove implant? Now, remember, the surgery may be by MIPO. Debridement is always open because the plate surface and underneath is likely to get infected. So whenever you are debribing for infection after MIPO, convert it into open 100% cases. 100% cases. There's nothing like MIPO debribement. When? As early as possible. If you suspect infection, as early as possible. We will, of course, elaborate this in the third module.
Question on counseling, sir. Maybe we can get to that question in the next module when we discuss early postoperative infection.
That's right. I think so. Yeah. I think so. Maybe you can unmute yourself, friends. If you want to ask any direct question, please go ahead. Or even start your video and you can ask questions. Yes, Tana, you have any question?
Yes, sir. Good evening, everybody.
Good
Thank
evening.
you for the wonderful talk here, sir. There's one thing that I would like to ask. So in a clean case, when we are following the 3 antibiotic doses regimen, we follow that even in case of a catheter, urinary catheter placed in, I'm still giving 3 doses, as I had learned that from Dr. Tanna and Dr. Asim Negi, sir. So, and we could not, you had mentioned that urinary catheterization is a factor, but you did not go into the detail. Does it require an increase in frequency or dosage, or since urine is considered sterile, do we take that into picture in some way?
So you mean to say, if the catheter is on, should you continue antibiotics?
Yes, sir.
Correct?
Yes.
Yeah. Generally, no. There are many people who advocate one shot of antibiotic when you're taking out the catheter.
Okay.
But otherwise, it is not necessary. Am I right, Dr. Aisha?
Yeah, absolutely. Catheter should not be a reason to prolong antibiotics at all.
And if I may add here, what about the drain that we put in?
Either. So regardless of how long you want to keep your drain, the duration of antibiotic for a clean surgery, as you said, should be within 24 hours.
Okay. Thank you.
All in all, the duration of drain is, there are many people who say that avoid drain, number one. And number two, the duration from a fixed 48 hours has come down drastically now. So most of the people try to remove drain at 24 hours.
Okay.
But irrespective of the drain, the antibiotics are stopped at 24 hours.
Okay. Thank you, sir.
And as far as the urine infection is concerned, even there's a recommendation by the European Society that if the patient has, we have a tendency of doing urine microscopy tests before joint replacement. They say that if the patient has asymptomatic bacteriuria, even if you get bacteria, just ignore it. Unless the patient has symptoms, just ignore that. You don't even need to test.
Okay. Thank you. Thank you, sir.
What are the agents which can be used to inhibit or disrupt biofilm?
Yeah, so by agents, you mean the antibiotics?
Yes.
Yeah, so those are the ones, I've listed them in my presentation, all the possible biofilm drugs. Yeah, they're there. The most important gram positive would be rifampicin. The most important gram negative for gram negative organisms would be the fluoroquinolones, especially ciprofloxacin.
Okay, there's a question to me. Do you follow up with oral antibiotics after clean surgery? No. We stop antibiotics at 24 hours and we do not follow it up with oral antibiotics. So the total duration of antibiotics is 24 hours. 3 doses of generally first generation. If it is not available, then second generation. Any other question? There are no more questions. Yeah, Tana,
Yes,
you
sir.
have a question?
Yes, sir. Yes, sir.
Yeah.
I'm sorry to bother you again with that.
No.
But you had shown us a photo with the MIC, then the breakpoint, and when the when the dosage was increasing, it was getting resistant. I did not understand that point. If a drug is given at a higher dose, the bacteria are resistant to it, or what did that entire concept portray?
No, I'm not sure I get you, Tanak. That the dose or the MIC was increasing. Like,
That entire part was very unclear to me. In the photo where there were multiple columns and
right.
there were 3 columns
So,
for
no. So there, the 3 columns were the breakpoints for sensitivity, intermediate breakpoint, and resistant breakpoint.
yes ma'am, that one.
Yeah. So the sensitive breakpoint will always be the lowest because that is the lowest concentration of the drug, which will, inhibit the growth of the organism.
Okay.
Yeah. And the resistant breakpoint will always be higher.
So the resistant breakpoint by definition would be?
So the resistant breakpoint is that critical point beyond which the drug will be resistant. Anything beyond that, if the MIC is beyond that particular number, say the resistant breakpoint is 0.5. So
Okay.
anything more than 0.5 will be resistant and you cannot use that drug.
Toxic to the body, or the bacteria is resistant to the drug?
The bacteria is resistant.
Okay.
The antibiotic is resistant to that bacteria. It's not to do with the toxicity in the body at all. Minimum inhibitory concentration is the relation between the bacteria and the antibiotic.
Yes, ma'am. So the lowest dose is susceptible, but the higher dose is not susceptible.
It's not the dose. It's not the dose. It's not the it's the concentration of the drug.
Yes,
All
ma'am.
right. What they're basically trying to tell you over there is that if the MIC,
Yes.
okay, so let's take vancomycin for an
Yes, ma'am.
MRSA. Okay. So if the MIC of vancomycin has come to 0.5.
Okay.
Okay. For Staph aureus, I
Yes.
say that the sensitivity breakpoint is 1.
Okay.
Okay. Then 0.5 means that MIC of 0.5 means that vancomycin is susceptible.
Okay. Okay.
Okay.
Yes.
Now I say that the intermediate breakpoint, all right, is 4, which means that if the MIC of vancomycin is between 1 and 4, then it is considered intermediate, which means I will have to increase the dose of the vancomycin.
I got your point. I got
Now
your
you
point.
got it?
Yes.
Okay.
Ma'am. Thank you for explaining that, ma'am.
Okay, there are a few questions about in case of pouring pus. Sorry, many times we operate in other doctors' operation theater. How much can we trust them? Do we need extended antibiotic course? Now, all in all, we must improve our theater conditions and theater discipline. That is the reason why we are having this OT my temple concept. But there is no point in increasing antibiotic period because you don't trust the theater. That is something we will explain you during our debate and post debate. So next time we will continue with that debate and we'll explain why extending antibiotics is not useful. In case of pouring pus, giving betadine and hydrogen peroxide wash, will it help? Generally, no. These days, it is believed that it's not very useful.
There is a question on preoperative culture of blood, urine, throat in arthroplasty cases. So urine, like I said, there is no need to culture it. There's a clear study on that. That as long as the patient is asymptomatic, don't bother with it. Same with blood. Unless the patient has fever and is suspecting sepsis, blood culture is not done. And in those cases, arthroplasty should certainly be delayed. Throat culture, Dr. Aisha, other than an MRSA swab or nasal MRSA swab or an axillary MRSA swab.
No role of throat.
No.
Does the duration of surgery and soft tissue handling decide the duration of the antibiotic and what antibiotic is given postoperatively?
If the surgery is delayed beyond 3 hours or 4 hours, it is best to repeat prophylactic antibiotic. And even if the blood loss is more than, say, 1500 cc, then you need to repeat the antibiotic. But total duration remains same.
So post-op 24 hours is standard.
Yes. Should we consider social background or place where patient is going to live till suture removal while giving oral antibiotics? Generally, no. Generally, no. I mean, once you have sealed the wound, it has sealed the wound. Unless, of course, you suspect that there is infection. Then things are entirely different. Then you need to find out whether it is infected or not before actually continuing antibiotics. You would like to add anything, Dr. Aisha and Dr. Aditya?
No, I think that hits the nail on the head. Before starting antibiotics, a wound wash, even a slight wound wash would be better, rather than just empirically giving antibiotics and then hoping that it works.
Lastly, Aditya, if you could explain asymptomatic UTI bacteria, do you need to treat?
So, Dr. Surendran, UTI is never asymptomatic. UTI is urinary tract infection. Dr. Aisha, if I'm correct,
Yeah.
UTI means there are
is
symptoms.
asymptomatic bacteriuria, which means
Correct.
the patient is asymptomatic, but the urine keeps showing pus cells. Right? So I have 1 or 2 slides on it. If you want me to show it, but basically
Yeah,
I can
please.
just, shall I do that or shall I?
Yeah, please. If you have slides, please go ahead.
Okay, so this is exactly, sorry, what just happened? Can you see my slide?
Yes.
Yeah. So this is exactly what we were talking about, that say you have an uncontrolled diabetic, obese, posted for open reduction or for closed fracture. And this kind of reference comes to us very often, that somebody has just done a urine culture before surgery. Patient is quite asymptomatic. How do you treat this? So you can decide, would you change your surgical prophylaxis because you've seen this? Would you delay surgery? So we get these references quite often from not just orthopedics, but various surgical departments. When we see this, we have a set of checklist questions, which we run through all our students and everything whenever we are training them. Does this patient have fever? Does this patient have any symptoms of a urinary tract infection, any dysuria? It becomes particularly difficult when you have a catheterized patient, some elderly patients who have chronic indwelling catheters. Very difficult to say dysuria symptoms, but any stranguria, any abdominal discomfort, any chills, even diabetic patients will not get fever, they will just get chills. So those are things to look out for. How was the sample collected? Was the patient voiding freely? Was the patient catheterized? If the patient was catheterized, patient is asymptomatic, any catheter which is indwelling for more than 24 hours, you cannot interpret the result, because any catheter which is indwelling for more than 24 hours will be colonized with bacteria. There will be a certain amount of pyuria, and anything you grow on such a catheter in an asymptomatic patient, you can never say whether it's colonization or true infection. So how was it collected? Free voiding or catheter? Was a contaminant urine routine, was a concomitant urine routine set? That is very important. Sometimes we just have a culture, we don't have a urine routine to corroborate the findings. Is there a possibility of a contaminant or a colonizer? Is this an obese patient, an immobile patient? Would it be difficult for this patient to collect a sterile collection? Who has collected it? How was it collected? And then, of course, we come to the question of treating asymptomatic bacteriuria. So just very simply, when you look at a urine routine report, there are some things that can help you. All right. So bacteria should be absent in your urine routine report. Any amount of bacteria has a high specificity for infection, but a low sensitivity, which means bacteria can come from a poorly contaminated collection. Okay. WBC is less than pyuria is what we look for. We understand that. Nitrite can give us an idea of certain kind of organisms, gram-negative organisms in the bacteria. Again, it will have low sensitivity, easily contaminated, but high specificity. What is important to see is when you see your WBCs, you see your pus cells and you feel sufficiently satisfied that no, this is an infection, always look at the concomitant squamous epithelial cells. If the squamous epithelial cells are less than 5, that indicates that it is a properly collected sample, fraught with less sort of risk of contamination during collection. So high epithelial cells indicate contamination with skin flora, and such a sample should be viewed with a certain amount of mistrust, and you need to repeat. Okay. So yeah. So question was, would we treat an asymptomatic patient even if we are finding that they actually have a properly collected sample with pyuria, with an organism growing? A lot of diabetics, a lot of elderly people just have pyuria and organisms in their urine, and it doesn't really mean anything. Yes, earlier we used to worry, especially when there was an implant to be inserted during surgery, and wonder whether we could treat, but there have been enough studies to show that treatment really doesn't change outcome, doesn't make a difference to the outcome. So if the patient is symptomatic, by all means treat the infection, then go ahead with whatever elective surgery that you're planning.
Thank you, Aisha. Thanks a lot. I think that about clears all the doubts about asymptomatic pyuria, or not pyuria, WBCs in the urine.
And the same applies to fungus also in the urine. You get candida in the urine, unless the patient is symptomatic, please don't treat it.
Yes. Yeah. Thanks a lot. Thanks a lot. I think that's about all wraps up our module today. Thank you very much, Dr. Aisha and Dr. Aditya. And see you next Saturday. See you next Saturday. Thank you. Thanks a lot.
Thank you.
Bye, everybody.
Bye-bye.
And do keep communicating on the WhatsApp group if you have any doubts. Bye.
Yeah. Bye. Thank you, sir. Thank you, Dr.
Thanks, sir.
Thank you, sir.
Thank you.